the aging population is the fastest growing population on the planet. We're living longer with multiple chronic conditions usually. It's not unusual for me to treat patients who have 4, 5, 6 comorbidities at the same time, and that's usually not even the reason that they're seeing me. You sort of think that because you're old you can't do much, and they really can do a lot more than that.
I'm excited today for this mini podcast I'm going to have with this amazing person that I'm with. His name is Dr. Hartley. He has a lot of certifications and he has a lot of really achievable things that we all strive to. But I think before I mention them, one of the things that most describes him would be, I think, one of the awards he got with the APTA, which is the Catherine Worthingham Fellow, which is awarded for these professionals that give maybe more than 15 years of excellence and trying to improve the profession, and also just promote other people doing the same thing. And in my case, I got the chance to see it firsthand, because even though he has all these responsibilities, when I was in Puerto Rico and we went through Hurricane Maria, kind of like the year after, I met this other amazing person, which pretty sure you remember, Johanna Segura.
Yeah.
She's Johanna Reyes now, because she's married. But basically, she connected us to see if I could be part of the conclave in Miami, of the University of Miami. And I sent an email to Dr. Hartley, and he responded in less than 15 minutes. To a student, I still remember the minutes.
That sounds right.
To a student that is not related to his university. And that's how everything started with my journey in physical therapy outside of Puerto Rico. And basically, that brought me a little bit more purpose to help my colleagues and classmates to get here and come to the conference. And I had a little more responsibility, which was really exciting. But yeah, that's a little bit of what kind of a person Dr. Hartley is. But just to describe a little of all the things he has achieved and has worked hard for, he's a physical therapist. He's board certified geriatric specialist. He served as president and many other roles also inside of the Academy of Geriatrics in the APTA. He also has been recognized for the best article published in the Journal of Geriatric Physical Therapy. He is the founder of the first residency of the Geriatrics Academy, and he also has served in the Florida Board of Directors Physical Therapy Association. He has many other stuff, which I could go through, but I feel like I want to jump into you guys hearing him speak. But yeah, I just wanted to give you a small detail of all the things he's been part of and still is. But he's currently in the University of Miami in the program of physical therapy. Before we start, I wanted to ask, what is something that you enjoy that is not related to physical therapy?
Two things really that come to mind. One is running. I do that to de-stress and to get my mind sort of outside of PT, and travel. Yeah, I love to travel. So every little chance I get, even if it's just like a 3 or 4 day trip somewhere, I try to go. So awesome. I enjoy that.
Yeah, no, and now that he says travel, I'm going to add that he's going to be, one of the reasons I'm speaking with him, because I'm excited, he's going to be in Puerto Rico.
That's right.
And probably when this comes out, it's probably closer to the date when it's going to be the conference, but he's going to be speaking in one of the conferences of the Physical Therapy Association in Puerto Rico. Yep. So I'm excited for people to hear him and know him a little bit more. And he might speak a little bit in Spanish, right?
Maybe. We'll see.
You were saying you're gonna be in Puerto Rico for the conference in October, which I'm excited for, and you're excited for.
Yes.
And we just learned that one of the other persons who's gonna be on the conference is a really close friend from you, right?
Yeah, I mean, it was really funny when I learned that Dr. Morris is going to be the other speaker at the conference. I didn't know that until 30 minutes ago. And David Morris was my clinical instructor when I was a student, and we have been very close friends for more than 30 years. So
You guys are gonna have a blast in
it'll
Puerto
be
Rico.
fun. It'll be fun.
And then you were saying that you run, so like you said
yeah.
something about how many miles you run every.
I try to do 5 miles when I run. I usually do. I have a sort of a 5 mile track that not a track, but a trail that I run. And I try to do that about 3 days a week. It's been hard lately because of the heat, but I've skipped a few days. But hopefully I'll be back out there tomorrow.
No, that's important. Stay active, right? That's what we promote.
Absolutely.
We got to do it also.
Yeah.
So I was also gonna ask. So what are you planning on sharing with the professionals that are hearing you in Puerto Rico on that conference? Obviously, you don't have to say what you're gonna talk about, but at least share a little bit of what you're planning on speaking at.
I'll be happy to. So as you mentioned, I'm board certified in geriatrics. I was president of the Academy of Geriatrics for a bit. And that is a population that I care a lot about. It's my area of specialty and an area that I'm pretty passionate about. So that's what I'm talking about, is geriatric rehabilitation. And what I'll do is sort of give a little bit of overview around the demographics of that population specific to the United States, but I'm also going to dig deep into the demographics of Puerto Rico and talk specifically about the aging population there. It turns out Puerto Rico has some really unique and interesting social issues around the aging population that are different from mainland U.S. So I'll highlight some of those differences. The aging population is the fastest growing population on the planet, and we just don't have enough clinical professionals, specifically physical therapists, to manage those issues related to aging. We're living longer with multiple chronic conditions usually. It's not unusual for me to treat patients who have 4, 5, 6 comorbidities at the same time, and that's usually not even the reason that they're seeing me. And so those issues compound the complexity that we encounter when we're treating these patients. So that'll be part of it. The other piece of it is that when physical therapists kind of have a history of underdosing treatment in aging adults, just maybe that's partly because of our own inherent ageism, and we sort of think that because you're old you can't do much. I don't think there's enough yellow TheraBand on the planet for how we actually dose most aging adults. And they really can do a lot more than that. I mean, I'm not young anymore, and I'm out there running 5 miles 3 days a week. And a lot of aging adults can do much more than we think they can do. So the real theme of the clinical part of my talk is going to be around proper dosing for exercise for aging adults and challenging them appropriately to really make a difference, because I think the underdosing is not only bad for the patient, it's bad for healthcare in general, because our patients don't get better as quickly as they could, and so we add cost every time we sort of prolong care because we aren't dosing appropriately. So the problem just gets bigger and bigger.
No, yeah, and I'm pretty awesome that you kind of like touch into the demographics of Puerto Rico, which there's another aspect of it that there's a lot of professionals that are graduating from Puerto Rico. Well, some of them are just don't want to have opportunities and want to get residence and doing a more experience with like the specialty aspect of things, and they leave. But most of the things that are happening is they are leaving because the opportunities in Puerto Rico does not reward them staying. So the people that are older adults are suffering those consequences.
Exactly. Right. So yeah, Puerto Rico is unique in that it's just sort of a microcosm of the rest of the world, except magnified in sort of the concentration on an island. So it gets exacerbated, I think, just because of the physical geography of where it is.
Yeah. No, I agree. And I was going to jump a little bit. Now that we're still talking about this, I'm just going to ask this question before I jump to the other ones. what is the importance, which you kind of answer it, of rehabilitation for you?
The importance of rehab.
Yeah.
Well, I can answer that a lot of different ways, I think. For on a micro individual level, the importance of rehab is to improve function and to improve quality of life, even as we live longer in terms of the quantity of life. It's not always with high quality. And so on an individual level, I think rehabilitation improves quality of life as we gain quantity in years. On a more systemic level and organizational or societal level, rehabilitation does the same. It improves quality of life, but the impact there is on cost, on improving access, in improving socialization, improving even mental health and other things, because we can keep people in the community, we can reduce institutionalization, decreasing the burden of care on caregivers, but also decreasing the burden of care on governments and other entities that generally pay for those things. So there's an economic benefit, there's a social benefit,
There's an individual benefit.
all of those. Yeah.
No, I like that answer, which you kind of touched different aspect of it. So I was gonna ask more like more personal question that kind of connect with everything you do, because you have a lot of stuff in your plate, you have a lot of responsibilities, and you could just say I'm done, right? So I wanted to ask, what drives you to keep doing more and more? Obviously for the people that you're helping, and also for the profession, and also for the students.
Yeah. So for patients, it's what I've said. I mean, it's really not more than that, other than improving quality of life. And I really feel like in geriatrics, I can make a huge difference in somebody's life. And you know, a small, seemingly small thing can do something as big as prevent, you know, placement in a nursing home or something. So that's meaningful to me. On the professional level, in the service and the APTA stuff, and the, you know, the APTA geriatrics and the leadership things, there I feel like I am able to make a difference in policy and in how our profession engages with the rest of healthcare and with policymakers and with patients. And so I feel like at a very high level, I'm having sort of a bigger impact, and I can have a role in change that happens. Our profession has changed so much since I've been a physical therapist. I graduated from this program at the University of Miami in 1990. And so, you know, going on 35-ish years of practice as a physical therapist, a lot has changed in that time, with the education moving now to a doctoral degree, us having direct access. So many things have changed in the political world, in the advocacy world, in the scope of practice space, what we can do, that I just felt like I wanted to be part of that movement. And so that gave me that service within APTA, gave me an avenue to do that. Lately, obviously, I'm teaching now at the University of Miami. I've been doing that for the last 10 years full time. And in this role, I feel like I also am having an impact on sort of what the future will be. Obviously, I think most people who are in academia would say something similar around teaching students, but I find it engaging. It feels like it's a cutting edge place for me to be, not just with teaching students, but also giving me the ability to do research and be engaged with the kind of research that I like, which is really education research. I'm very involved in mostly post-professional residency education research. So that's always been fun and something that I'm very passionate about still.
Yeah, I was gonna ask you about the research aspect, because I know you've been involved in a lot of articles, and I wanted to ask obviously it kind of like I think you have answered it a little bit, but I just wanted you to speak more towards it. What is the importance of the research in health professions?
So, in general, I think research has to be important because we need to be making evidence-based decisions. And so we shouldn't be treating patients based on anecdote, based on what we think works, or based on even like the latest fads. For example, going to a Con Ed course and learning some new technique, and then coming back to the clinic on Monday and believing that every patient you treat needs that technique because it's new, it's shiny, it's flashy, it's catchy, it's trendy. That's kind of been part of the history in physical therapy. I think we not unlike many other health professions sometimes gravitate to trendy, flashy things that don't always have a lot of evidence behind them. And so following the evidence and understanding how to integrate that into practice is fundamental to being a profession that is respected and one that I think will gain additional authority in the practice space as we embrace that evidence. Because if we're making our decisions based on anecdote or trends or fads, then that's never going to get us much clout in the professional space. So evidence is important in terms of healthcare overall. Is that what you were asking?
No, that's what I was asking. I think that's perfect. I agree with it, and that's where the clinical practice guidelines also comes into effect, which I think you also been a part of.
Yeah, so CPGs or clinical practice guidelines, which I'll touch on at the conference in Puerto Rico. I'll be really integrating a CPG on the management of patients with osteoporosis into my talk. That was one that I co-authored with a team of people that worked on putting this together. And a clinical practice guideline, I think it's important for people to understand, is really it's an evidence-based document that is a synthesis of all the other research that's been done. So let me tell you why that's important. I just said evidence-based practice is important. Well, the volume and the amount of evidence that gets published today in 2020 is staggering. And there is no way that you, me, or a team of us can keep up with what's published. You can't. It's no way for you to read it and know it and integrate it into what you're going to do with a patient. You need somebody else to synthesize all that evidence to tell you, all right, this study came out and it says you should do X for patients with osteoporosis. This study came out and it says you should do Y with patients for osteoporosis. This one says X is good, this one says Y is good. So at the end of reading all of these studies, which is good, X or Y? And you may or may not be able to discern that based on how the quality of those individual studies. So a CPG puts all of those studies together and synthesizes it into very much like a systematic review, a meta-analysis. It takes that data, synthesizes it, and based on the quality of the research, because there's some that's good and some that's not, and based on all of that information that goes into compiling it, a recommendation is made. So the guideline will say physical therapist should do blank. Physical therapist should not do blank, whatever it is. Those statements are written very intentionally based on the quality of the evidence that's out there. So a CPG is not really, it's not a bunch of people sitting around a table just coming to an agreement on what they think is good. CPG is based on just the quality of evidence that's been published over a period of time and then making a recommendation based on the strength of that evidence. So to give clinicians guidance in terms of what to do, not to prescribe or tell people you must do this, but to give people guidance around what the evidence says they should do. Now, if people deviate from what the guideline says, that's not a crime. You can do that. But I think you should have a really, really good defense for why you do it. So if you're not following a guideline, when the guideline says, Kelvin, the preponderance of evidence says you ought to be doing this with your patient, and then you say, yeah, Greg, but I'm not going to do it. You should have a good reason why you're not going to do it, a really good reason. And that should be reflected in your documentation and why you're not following a guideline. When the guidelines are out there, we ought to be using them. And I think we don't do a good job of employing those guidelines. We sort of do what we think works. We do what we like. We do what's easy sometimes. Or we do what's trendy. And often those don't have a ton of evidence behind them. So if you're not doing what has the evidence, you should have a good reason.
Yep.
And that's really what the role of a clinical guideline.
Yeah, and it goes with what we were saying before, like the trendy aspect, that going on Instagram or watching a video and seeing people because they have a lot of followers, they know what they're doing, which is like a little bit more of a psychological, with which you actually have an undergrad on psychology.
I do, yeah.
Which I think that works a lot on the psychology of the clinician. Well, people are gonna like this; they're gonna come to my clinic. Which there's like a marketing aspect to it too.
Right. You know, social media has had a really big impact, I think, on thinking, and that impact is not good because it's taken away a lot of critical thinking. We really like, 10 or 15-second reels that we can scroll through, and we get addicted to that kind of information. That tell me in 10 seconds what you're going to say, and if that's not what people are getting, then they don't read it, they don't pay attention to it, and it's become less useful to them in some way. And then, because somebody has X number of followers, they put authority into that message, and that too is a mistake.
Yeah.
So, I don't know where all that leads us. I know where it has led us so far, and not made me really happy around how people are seemingly less able to make good decisions based on, not solely because of social media, but I think that has an impact. Yeah. So be careful with that.
Yeah, of course. And I was gonna say, jumping into the residency aspect of things, we were talking before today, which I learned a little bit from what we were chatting about the probability of PT programs, or that they already exist, but moving to 2 years instead of 3 years, and the idea of promoting doing a specialty right after finishing the diploma on physical therapy.
So that's been a conversation for a while. I've been involved in residency education for physical therapists for 20 years, I guess, and I chaired the accreditation board for a little while. I've been involved in establishment of residency education programs here in the U.S. in all the different specialties: orthopedics, sports, pediatrics, all of them. For, like I said, for 20 years. And in this 20-year time frame, there's been a large conversation around what the role of residency education is. And clearly it is a way to train someone to become a specialist, and not just become any specialist, but hopefully become an expert specialist, or at least on their way to becoming a master clinician within that area of specialty practice. It's far more than just gaining knowledge to be able to pass a test. It is really validation that you have acquired the skills and the clinical reasoning that goes with being a specialist in your area of practice. So that's really what a residency is. So within physical therapy, residencies have come after we already had an existing process for people to become board certified. So for example, I got board certified in geriatrics long before any residency programs existed. It was not even an option for me. And most people my age, that was never an option. So we had a way to become a board certified specialist without really having a way to train people to learn to become a board certified specialist. They sort of had to teach themselves and pass a test, which is the way still a lot of people become board certified. They teach themselves, They study on their own, and you can still sit for the board certification exam without doing a residency. So there's been conversation around whether or not there should be at some point a mandate that if you're going to become board certified, you need to complete a residency program. This is the way most professions do it. Medicine is obviously the easiest example to look at, but that's not, they're not alone. They do the same in pharmacy. They do the same in many other professions. So that's, I think, one early way that we could make a change in our profession that for me feels right. But we can't do that until we have enough residency programs. And right now we don't have enough residency programs to say you must do a residency before you can become a board certified specialist. So that's one conversation. Simultaneously, there's been another conversation around the length of time it takes to become a physical therapist in the United States, 3 years, the degree that you obtain in the United States, the DPT, and the cost of that education in 2023, which is pretty high. And also around the return on investment for the amount of money that generally people have to borrow, and what that return on that investment is in terms of earning potential for a new grad DPT. And there is a tipping point where the return on the investment is not worth the investment. And so in terms of just pure economics, right? So there has been discussion around what could we do to reduce the cost of the overall DPT education. And one mechanism to do that could be reduce the time that it takes to become a DPT. But in order to do that, I think we couldn't just trim off a year or even 6 months without also somehow saying that you must complete some additional clinical training under supervision before you can just treat patients on your own. Now, there's a lot more to it than I can explain in this podcast. But this is not dissimilar to what they do in most other professions that have postgraduate training programs. Medicine, for example, is easiest example, and I'm not saying that we need to imitate medicine. We're not trying to be physicians, but they do have a stepped licensure process where they graduate, they take an exam. That exam validates that they have some knowledge, but it doesn't give them the ability to practice unsupervised. They still must complete a residency training in a specialty area of practice, whether that's dermatology or pediatrics or cardiology or orthopedic surgery. And then after they've completed their residency, they take a second exam, or in the case of medicine, it's a third one. And then they can practice completely independently after they have completed their residency training. There's been some conversation in physical therapy about moving to a model like that. I think it will take a long time for us to have capacity to even say we could do it. And then I think it will take even longer for there to be any agreement in the professional world and in the education world for people to agree that that's the right thing to do. Maybe it's not choosing a specialty area, because maybe right out of school as a new grad PT, you don't know yet that you want to work in geriatrics or pediatrics or sports or neurology. Maybe you aren't ready to commit to a specialty area of practice yet. So I think in physical therapy, we have to do some work to define what general practice looks like in physical therapy and define primary care or general practice as an area of specialty practice. So the analogy in medicine is, a GP or a general practice physician in medicine can do a residency in primary care, they can do a residency in family medicine, and they can do a residency in internal medicine. All three of those medical specialties are really general practice, and they can choose one and they become a GP at the end of it, or a primary care physician, or a family medicine physician, or an internal medicine physician, all sort of general practice physicians. We don't have the equivalent of that in physical therapy. where you can become board certified in a specialty, but yet still be a general practitioner. And so I think once we figure out how to do that, then a more serious conversation about compulsory residency training for physical therapists can happen. But we can't really have that conversation yet because it's, for me, just kind of pie in the sky. I think it's a nice dream to have and a goal, and I would love to see us move in that direction. I do think, though, that if we move to compulsory residency education, which I think is the right thing to do for society, it's the right thing to do for patients, then we would have to seriously look at the length of the DPT education, because I don't think we can add a fourth year. We can't do 3 years of DPT plus another year of residency. So we have to cut somewhere if we're going to add the residency. So that too, I think, has some financial rewards, because by cutting some of the DPT time, you are reducing the tuition burden on the student. And remember, residents are paid, so residents earn a salary. There is no, generally, there are some exceptions, but in general, residents earn income as opposed to borrowing to pay tuition.
No, that makes sense.
Yeah.
But yeah, no, I would say this could be a long conversation, right?
Yeah.
I was just gonna throw in there that interestingly, in Puerto Rico, we actually do 4 years of DPT
Yes,
school.
that's
I don't
right.
know if you knew, if I told you before. We actually do 4 years of DPT school. I think we have a couple more hours of clinical hours than usually programs have, and we have a little bit more research thrown in the curriculum. But that's something that is in Puerto Rico. Obviously, in Puerto Rico, we get a little bit less of the burden
Yes.
in the aspect of economically.
Right.
Like the education is a lot cheaper compared to here, even though it's the same education we're getting here.
Right.
Which that's the difference, but still 4 years over there.
Yeah.
Which is interesting. I was gonna say, so this is a lot of the topics of the research, which is obviously going to lead to things that can cause other medical problems like falls. So what is, if you were to say, let's say that someone that is not in the health profession, that is not a physical therapist and is just listening to this and has a mom or a dad or is a person that is getting into age and is getting hard to move around, what is something that you would tell them about falls and balance and the importance of working on those things to avoid other complications?
Yeah. So, that's a really good point. So generally, anybody over the age of 55 or so should at least once a year mentally note, have I fallen in the last year at all? And if you haven't, great, no risk. But if you have had a fall in the last year, then you should be checked by a physical therapist. Falls are the leading cause of death, accidental death, in aging adults in the United States. They're the number one reason people seek emergency care, the number one reason. So often what happens is people fall, they end up going to the emergency department. The emergency department rules out that they don't have a concussion, they don't have a fracture, nothing terrible happened, and they send them home. But they don't ever treat what caused the fall. And so many people really could benefit from balance training, strength training, and getting a screen for falls, and also the emergency department visits. And so, I think that particularly for aging adults, we should, as a physical therapist, be proponents of doing like an annual visit with our patients, just like you see a dentist every year or you see a physician every year once you're of a certain age anyway. Patients should see a physical therapist for a movement assessment, and that would include screening for fall risk and screening for frailty and screening for weakness and asking simple questions. Do you have difficulty getting out of a chair or getting off a toilet or whatever the case may be? Those are common problems with aging adults. And if we recognize some of those symptoms early, I think we could prevent a lot of ill-fated consequences downstream, like emergency room visits. So there is a a benefit again to the individual, and then coming full circle, there's that benefit to society because we have reduced utilization, we've reduced cost, we've reduced the burden of care on individuals, but also institutions and society as well. So there's, I think, a big role for doing something that is really not that difficult to do.
That's important. And I was gonna ask one one last question, which I think is one of the reasons that you keep doing this. That you explained before, you want to see the future of the profession improve. But there's a lot of people who probably might at some point see this video when they're interested in studying physical therapy, and they probably put in a search physical therapy school and stuff like that. This might come up, and they might be undecided on whether they should or should not. And obviously, we discuss a lot of stuff, challenges in the profession, things that are good. So they are probably like in between. Should I go for it? Should I not? Like, what if you were to say an advice? Obviously, they're gonna choose what they think is best for them. But if you're gonna give an advice, given your experience with students and everything, what would you say to them?
Physical therapy is a terrific career, and physical therapy has a very bright future. I think, like any profession and any job, really, it has its challenges. We grow. This profession has grown and changed so much over the last 30 years. We alluded to that. And part of what I think we are going through as a profession are just growing pains and learning how to fit in our new shoes, so to speak, and breaking those in. And I think we will continue to do that as we evolve as a doctoring profession in the United States. And so there will always be some growing pains because we are kind of going through some change. That said, PT is a great career. You can make a really good living in physical therapy. You can help people if you want to help people. PT is a wonderful career, and my specialty in geriatrics is about taking care of aging adults, and really I chose that specialty because I felt like doing small things, seemingly small things, can make a huge difference in somebody's life, including, preventing them from having to go to a nursing home, keeping them from having a fall and going to the emergency room, keeping them from breaking a hip, keeping them from whatever. Many of the things that I feel like I do as a physical therapist have a direct relationship to these big potential complications with aging. But it doesn't have to be in geriatrics, right? You can do so much in physical therapy. Pediatrics is a wonderful area of PT. Neurology, orthopedics, sports, pelvic health, oncology, cardiovascular pulmonary, many areas that you can specialize in physical therapy, or, as we talked about, you can do general practice, right? You don't have to specialize in an area in physical therapy right now. So there's a lot of places that you can work. You can work in a school system, you can work in a clinic, you can work in industry, you can teach, you can do all kinds of things as a physical therapist. And so it has been a rewarding career for me, and one that I would encourage anybody to look at.
Yeah, no, I agree with all the things you said, and I want to say thank you for taking the time to sit with me, speaking about all those passionate things you work with every single day and want to share with people. I think this is a good thing that people want to share, because a lot of times it's so difficult to get access to people that have the experience as you have. So I feel like I'm passionate about sharing that with people that might not probably have access directly to you. So now they can hear you in Puerto Rico and in other places, and that'll be awesome.
Thank you for having me. This was a lot of fun. I cannot wait to be in Puerto Rico and meet all the therapists there. I'm very much looking forward to that. And this was fun. Thanks for having me.